Okay. We're going to try this again. So I can see now who's watching. So now no one's watching. They're probably on the old streams. Okay. Okay, I have 3 people watching. I'm sharing my slides. I'm glad you're here. Welcome. We are learning this technology together. We got 5 people. That's good. I'm here. You can hear and you can see. Oh, I'm so glad. Everyone can hear and see. This is great. I don't have to look at my face. I'm very happy. I hope everyone can hear and see. And I can see the comments. I like this much better. This is great. Once I get confirmation from Ivy and Jill, Ivy and Joni. Okay. All right. Okay, so what I was saying before, lung cancer, I didn't get very far, let's be honest. So we'll start again. Lung cancer used to be this major monolithic entity. Patients would be diagnosed with it and their outcomes were very poor. The first advance happened when we realized that not all lung cancers look the same under the microscope. So the first change really happened. So we hear about this name non-small cell lung cancer and small cell lung cancer. Really means actually that years ago a pathologist looked under the microscope, they looked at the cells and they said these cells are small, and they looked at the cells of another lung cancer, they said these cells are not so small. And that's how we have non-small cell and small cell. And we learned that those 2 types of lung cancer are very different. And then from there, we learned more. We learned that amongst non-small cell, we have adenocarcinoma. Adenocarcinoma refers to cancers that grow little glands in the tumor. Squamous cell looks more like the lining of parts of the body. But now where we are, we're in a much more complicated space, which is right here, which is now we're learning that different types of lung cancer have different mutations in them, and that these mutations or genetic alterations change the way the cancer behaves in a major way. So if you take a look at this slide, what you can see is this pie chart. Now, of course, for the purposes of this group, you see the green piece of the pie that says EGFR. And that means that there are certain tumors that have a mutation in EGFR that make that tumor behave like a tumor. And that's why when we give very targeted therapies for EGFR, we can see very nice responses. But you can also see these ever shrinking pieces of the pie which refer to different types of lung cancer that we're really just learning about, and we're getting more and more targeted therapies for them. So one of the questions that I get a lot from patients is, what is a mutation? When I was a kid, this was my understanding of what a mutation was, is that, it allowed someone to shoot laser beams out of their eyes. When I got to medical school, I was very disappointed to realize that this is not actually what mutation does, and that in fact it can cause a lot of problems, but that there's a lot of words that get used. Doctors like me like to use a lot of big words, and so it's really important that we understand what these words mean. So first of all, when we think about a mutation, it's important to realize that there are multiple types of mutation. The first type of mutation that people generally think about is what's called a germline mutation. That's the kind of mutation that leads to cancers that can be inherited throughout a family line. So that's the type of mutation that will give a father blue eyes and then their child blue eyes. That's a genetic change that leads to blue eyes. Not that blue eyes are bad or good, it's just that's what the gene says. But the types of mutations we're talking about in lung cancer are generally somatic. That means that they're in the body. They're not in the sperm or ova, so they can't be passed along to subsequent generations. They're really within the tumor, but they're in every single cell of the tumor. And that means that no matter which part of the tumor you biopsy, you should be able to see it. Now, some of the words that doctors use to describe mutations can be quite confusing. So you see over here on the left side of the slide, we have these blue lines, and the blue lines are two, and the red are two chromosomes. And what we can see is that a mutation like the L858R mutation, for instance, in EGFR, changes one of these blue rectangles to green. The other type of mutation that can occur is a deletion. So you see over here in the red how this red chromosome is one rectangle smaller than the other chromosome. And that's like in EGFR, the exon 19 deletion. It's a deletion of part of the gene that is allowing the gene to make a protein. So the protein that gets made is not functioning correctly. In the case of EGFR, it's constantly on, but we'll get to that. The other type of genetic change which can be seen is what's called a translocation, which you can see on the right side of the slide. And what happens there is that you have two chromosomes, and part of one breaks off and goes on to the other piece. And this can be highly, highly problematic, because if you think about it, if you have a gene, each gene has an on switch and an off switch. So you imagine that you had a gene that said, this gene makes your hair grow. Well, you'd be perfectly happy with a on switch for that that's always on. You say, okay, your hair is always going to grow. Your fingernails are always going to grow. That's okay. But if you had a switch on a gene that controlled when cells grow, well, you wouldn't want that always on, because that's what cancer is. And so a translocation, something like the ALK translocation, often called the ALK fusion, can have that effect where an on switch gets put up next to a gene that shouldn't always be on. And that's when we have problems. So any questions about that? About what a mutation is as opposed to a translocation? This is complicated doctor words. Not seeing any comments. Cool. But if there are any questions, I'm happy to take them now. Great. Okay. So this is normal conditions. So under normal conditions, you have a gene, and the gene has an on switch and it has an off switch. So it's like if you have a lamp and the lamp is plugged in, right? You turn the lamp on, the lamp will turn on, right? The light will turn on. If you turn the lamp off, the lamp will turn off. And that's normal conditions. So something like EGFR is what's called an oncogene. An oncogene is a gene that when it gets mutated, it is stuck in the on format. And so in this setting, on the left, what you can see is you have a lamp. The lamp is plugged in. We've turned off the switch, but the light is still on. That is not good. That's a problem. And so what we do in that situation, if you had a lamp where the off switch was messed up, you would figure out a pretty easy solution. You'd unplug the lamp and the light would turn off, and you'd be able to go to sleep. Now, this is the sort of thing that happens for things like EGFR mutation, ALK translocation, ROS1 translocation, and BRAF mutation. These are oncogenes. So when they're mutated, they keep the cells going. And if we give an inhibitor for that oncogene, we can stop the growth of the cancer. Tumor suppressor genes are a little bit more complicated. Now, many of you may have had genetic sequencing done. You might have seen that there's a mutation in your cancer or in your loved one's cancer in something called TP53. If so, that's not surprising. TP53 is the body's off switch. It turns everything off. And if it is mutated, it means that the cancer, your body can't turn genes off. And the equivalent here would be, imagine if you had a lamp where the lamp is switched off, it's unplugged, but still you're getting sparks coming out of the wall and it's going through the wire and it's turning on the light anyway. That is a really big problem. That's a time you got to call an electrician, right? And so this is a big problem, and we actually don't at this point have very good ways to deal with tumor suppressor gene mutations. And that's why in something like small cell lung cancer, where things like TP53 and RB are very frequently mutated, we don't have targeted therapies, because even though it's only 1 or 2 mutations that are there, we don't have a way to turn off an off switch. And so that is a big problem. So why is targeted therapy important? I think that in this audience, I don't need to emphasize this, but it's important because it works. It works really, really well. This is a CAT scan here from the first publication of using crizotinib, an ALK inhibitor for ALK translocated non-small cell lung cancer. In the left side, you see here is the right lung and the left lung. I don't know if you can see my cursor. Can you see my cursor? No, I don't think you can. Anyway, in the left side of the slide, you can see that the left lung has a lot of grayish white areas, and what that is cancer. And you can see that at the first disease assessment after about 6 to 8 weeks of crizotinib, all of that had disappeared. And this really emphasizes how important it is to get the right treatment to the right patients, because we do not see this sort of treatment response for chemotherapy or immunotherapy. It really depends upon targeted therapy to lead this level of rapid and relatively durable responses. Oh, you can see the cursor. Thank you. Oh, cool. All right, so this is the stuff I was talking about as the cancer. This is really great. Look at this. This is wonderful. So this, but you see all of this melted away in this screen over here. And so that is really remarkable. So how do we test for alterations? This is a big question. So historically, you go back not that long ago, you go back 5 years. The way you would test for something like EGFR was using something called PCR, or polymerase chain reaction. For the science nerds in the audience, what happened is they actually take DNA and they raise it to a really high temperature, 95 degrees centigrade, and then they put it back together again using an enzyme. And the enzyme comes from a bacterium that grew in a geyser. So it's used to really hot temperatures. And so it allows the body, the experiment, to keep making more DNA so it can check for the presence of these mutations. The way we look for ALK and ROS1 and various fusions often is with something called FISH, or fluorescent in situ hybridization. And what they do there is they look for different sides of that translocation. So you remember how I said it was one part from one gene and one part from another? So what they do is they make a probe that can bind to each of the sides. And under a normal condition, those two sides should be very far from each other. And they take these probes and they put little fluorescent lights on them. They're not literally light bulbs. They're actually fluorescent emitting isotopes, but they're colored. And so what happens is you have one that's, for instance, yellow and one that's blue, and they should be completely separate. But when they're put near each other, the eye sees it as green. And so in this picture, what you see is they made one of them red and one of them green. But over here, you can see that the signals are close to each other. And so that is how we detect translocations. The oldest way we have for detecting any sort of change is called IHC, or immunohistochemistry. And literally what they do is they take pieces of the tumor and they stain it with various dyes that are actually antibodies, and then a pathologist looks under a microscope to identify what's going on. This is how we do something like PD-L1 testing for immunotherapy. There are some ways to test for ALK or for EGFR mutation using IHC, but they are less commonly used. Most people use other assays. But at Penn and at many centers around the country and indeed around the world, we are now moving away from those methods I spoke about, because the problem with those methods is that each time you do that test, you can only test for one gene. Now, this used to not be a problem, right? So if all we had was EGFR, well, then a single test is fine. But we now have so many genetic alterations to look for in non-small cell lung cancer that every time we do a serial test, it takes a little bit of tissue and a little bit of time. And unfortunately, patients with lung cancer, especially patients first diagnosed, they don't have a lot of either of those things. Usually the biopsies that are taken are very, very small. And so we can't just be wasting the tissue using 5 different tests. And so that's what next generation sequencing does, is instead of doing serial testing, it tests hundreds, sometimes thousands of genes all in parallel. And so at that point, the problem then becomes not getting enough tissue. It takes a little bit longer, but not that much longer. The problem is the bioinformatics. The bioinformatics reference, what am I going to do with this information? Any of you who have seen one of your next generation sequencing reports, and this is something like Foundation Medicine or Caris, or sometimes there are institutional panels which are run, that's when you're seeing these. And if you've ever seen one of your reports, they can be really overwhelming and really scary, because you'll see sometimes 20 different mutations and only one of them is clinically relevant. And that is really difficult to handle. The other problem is that not all next generation sequencing is the same. So most NGS panels that are done use DNA. DNA is the main source of genetic information in your body, okay? That's where all your genes are stored. But the body actually keeps the DNA as a double helix, two strands of DNA that are actually bound together like a coil, 2 coils wrapped around each other. You might imagine that if you wanted to get information from that DNA, you'd have to unwrap it. You'd have to unwrap those 2 coils because the good stuff's on the inside. And so what the body does is it does unwrap them and it converts them into something called RNA, which is a similar but a little bit different nuclear material. That RNA then gets spliced. It gets broken down from the pieces that make up the protein, called the exons, into the pieces that are just in between, as spacing material, called the introns. Those get cut out, and that forms this messenger RNA, which then gets converted into the protein, which then does all the stuff in your body. Now, why am I talking about all of this? I'm talking about all of this because if you do a DNA-based NGS, and an example of DNA-based NGS is Foundation, Caris, most next-generation sequencing profiles are DNA-based, you are going to have trouble identifying translocations. And the reason for that is that all the DNA-based assessments are based on the exons. And if you have lots of introns and the introns connect to each other on a fusion, it can make it really hard to know what you're actually looking at. So what we do at Penn and some other centers around the country are doing, I know they're doing this at Sloan Kettering, at UC San Diego, and some other sites, is we're doing a DNA-based next-generation sequencing, and then an RNA-based, it's actually a multiplex PCR, but it's an RNA-based next-generation sequencing, so-called Archer assay, to identify fusions and translocations. And so if I have a patient who comes to me who is a never smoker or a very light smoker who has a history of a new diagnosis of lung cancer, and their DNA-based NGS does not identify any mutations, I will then send the RNA-based assay if one is not already done. I'm lucky at Penn because my patients automatically all have both, but sometimes I'll see a second opinion and I want to make sure that they've had both as well. Does that make sense? This is really, really complicated stuff. Oh, I have a question. What do we do if our oncologists don't test for translocation and use RNA-based NGS? Can we ask our oncologist to send it out somewhere? That's a great question, Ivy. So yes, you definitely can, but we have to think about when you're going to do that, okay? So generally speaking, at diagnosis, if a patient already has a molecular driver seen, let's say they do the NGS assay, we see an EGFR mutation, then I would stop right there and get started on a tyrosine kinase inhibitor, something like osimertinib, okay? I would do it right then. It gets a little bit more complicated at the time of resistance. If someone is on a tyrosine kinase inhibitor, they're on a cancer pill, and they're progressing, in that setting, there are people who can develop resistance in the form of a translocation. So at that setting, I would push for doing an RNA-based NGS. My colleagues, Dr. Piotrowska and Dr. Sequist, reported of a patient who was on osimertinib, developed resistance, and the way they developed resistance was having a RET fusion. Now, a RET fusion, that sounds like a bunch of letters and gobbledygook, but the reason it's relevant is we now have really good drugs for the treatment of RET fusions. And so what Dr. Sequist and Piotrowska were able to do is they started the patient on one of these experimental drugs and the cancer melted away. And only by doing this sort of deep dive testing would we understand the mechanism of resistance for that person. So yes, you can ask your oncologist to do it. Sometimes you'll need to talk to them about it. Even say, look, I was seeing this talk on EGFR resistors from Dr. Baumel, or you don't have to give my name, it's fine. Just to say, look, was this sent for RNA-based testing? I heard that RNA-based testing is better for fusions. What I always tell my patients is no oncologist should ever be afraid of a patient seeking a second opinion or identifying another source of information. Because the truth is that this is your life. This is your very serious diagnosis, and your oncologist only goal is for you to get the best possible care. And so if I am seeing a patient and they say to me, look, Dr. Baumel, I heard about this test and I think it's going to help me, then I'll look into it and I'll see whether it will help them. And if we agree it's going to help them, then I do it. Because the goal is for them to get the best possible care. The goal is not for me to always be right. Okay? So it's a great question, Ivy, and I think that it's an important one. So who should be tested? At the time of diagnosis, any patient who has metastatic adenocarcinoma of the lung should be tested for mutations using a DNA, I would say DNA and an RNA-based test. Oh, the question from Ivy, is RNA NGS covered by insurance? I am certainly not an expert on insurance coverage, but what I can say is that at least at an institutional level, I have not had any problems with coverage for my patients. And the reason for that is I think that the institutions that are doing this are using this as a more of an exploratory research approach. And so they're billing based upon the DNA-based NGS, which is covered by the insurance. And they're using that, that effort to also do the RNA because it's not an increased effort for them, or not a substantially increased effort for them to do it. There are not very many commercial assays that are doing RNA. MSK Impact, I know, does have an RNA component, but it is not the component that is FDA approved. So it requires some maneuvering, but it is not insurmountable by any stretch of the imagination for nearly any oncologist to get access to an RNA-based assay. And so I'm seeing, Allie, that you didn't have a problem with Medicare coverage, and that's really that's the benchmark. Thank you for sharing that, Allie. So, you know, if Medicare is covering it, then the private insurers tend to follow suit. So other questions that often come up when we're talking about testing is, should patients who have a history of smoking be tested? The answer is absolutely 100% yes, they should. We should not be having a stigma attached to whether someone smoked in the past, because I have had patients who are heavy smokers who have had EGFR mutations, and you do not want to miss an option to help the patient. There are even some patients who have squamous cancers who I do testing on. Remember that our biopsies in metastatic setting are often a very small needle being put into the tumor. I know it doesn't feel like a small needle when it's going in, but it really is a very small needle. And so sometimes you can get a piece that looks squamous, but in fact is actually not squamous. So if I have a patient who's a never or light smoker with squamous disease, I will test that. Honestly, if I have any patient with lung cancer, I test them no matter what stage. And at this time, NGS testing is FDA approved one time for all patients with any cancer. Whether that's appropriate or not is a separate discussion. Oh, this is a great question. Is the Guardant liquid biopsy an RNA-based test? No, this was not answered. Thanks so much, Karen. So am I going to talk? I think I'm going to talk about liquid biopsies in a minute. But the answer to your question is no. It is a DNA-based test. It's based on circulating tumor DNA. There's actually very little circulating cell-free RNA. It breaks down relatively quickly. So the liquid biopsy is an important component of testing, but it does not necessarily address this concern. And in fact, because the liquid biopsy is a DNA-based assay and because of some other factors, it's believed that the sensitivity of liquid biopsies for translocations is worse than it is for mutations. So one of the questions that often comes up when I have a patient who comes in and they have had testing is they say, well, you know, how do I know if the testing was adequate? Because the truth is that many oncologists are, you know, we're not trained to do the testing. I personally am not trained to do the testing. I do this research and it's a passion of mine, so this is something that I'm interested in. But if you go to a community oncologist, they know about the management of every type of cancer, whereas all I know, all my brain is thinking about is lung and head and neck cancer. That's all I think about all day, every day. And so I can really dive into the weeds about this. And so sometimes oncologists will say to me, the tumor was tested. And I said, well, how was it tested? And they will say, well, it was tested. So what do you need to know as a patient? What should you be counseling your loved ones if you want to know if the testing was adequate? Is you want to make sure that it was tested for EGFR, ALK, ROS1, and NTRK, and you want to make sure that those are being tested for the translocations, because all three of those can have mutations as well, and those are not clinically relevant. And BRAF mutation, specifically V600E. And honestly, Ivy's question before, you should feel free to say, look, Dr. So-and-so, was next generation sequencing performed on my sample? Was an NGS test performed? And if not, you can ask why. And there might be a very good reason why not. But we just need to ask this so we can communicate and have clear pictures about what's going on. This is referencing what I was mentioning before. So I mentioned that RET inhibitors have lots of cool new drugs, and these are some of those. So Blue 667, Loxo 292, these, it's funny, my mentor always says that before drugs have names, they're license plates. So it's a bunch of letters and numbers, but these are drugs that target RET. Now, why am I including this here? I'm including this here because, remember I said before, RET can be very rarely a mechanism of resistance to EGFR inhibition. So for those of you who have never seen a waterfall plot before, these are waterfall plots. So I want to walk you through exactly what you're looking at here. So each of these columns is a person. They are a person on this clinical trial, okay? And this line represents the size of their tumor when they went on to the clinical trial. If the bar goes down, it means that their tumor got smaller. And if the bar goes up, as you see some went up over here, it means that their tumor got bigger. If the line goes below this dotted line, which you can faintly see there and more clearly see down here, it means that their tumor got smaller by 30%, which is our line of what we call a response. If the tumor goes down to a minus 100%, that's called a complete response. So you can see that both of these drugs are really quite good with nearly all patients having tumor shrinkage and very little toxicity seen. And so this is one of the reasons why when I have a patient who comes in who has not had comprehensive testing, I want to know what the mutations and translocations are. So if they have one of these, I can give them a very good treatment. I see we have a question from Amy here. So if we know that we have an EGFR mutation, they probably did NGS, is that correct? No, unfortunately, it's not necessarily correct. They could have done a PCR. It doesn't matter in the first line though, because if someone has an EGFR mutation, and whether you detect that by PCR or NGS, the result is the same, which is that we generally give them treatment with a pill. I most often use osimertinib in the first line. Okay. Let's see. Okay, so the key points to remember is that, this group notwithstanding, most patients do not have a targetable alteration, but as you well know, for those patients who do have that mutation or alteration, it makes a really big difference because the treatment is much better in terms of quality of life. It's much better in terms of response rate. And the other thing is that many of our other patients are receiving immunotherapy. And unfortunately, immunotherapy tends not to work for patients with a targetable alteration for many reasons that we can get to if it's of interest. So I'm going to move on to resistance. And this is, I think, a key issue that arises for patients who are on targeted therapies. This is an image that I borrowed from Dr. Piotrowska at MGH. This is the way we used to think about it. You have a tumor. All the tumor cells have EGFR mutation. They're all white. They're all sensitive. You give them a first or second generation tyrosine kinase inhibitor, something like erlotinib, gefitinib, afatinib, and what happens is some of the cells go away, and then some of the cells become resistant. These blue cells are indicated by, let's say, the T790 mutation. So you give them osimertinib, and you see that many of the cells go away. Now, at the time of resistance, you really don't know what's going on, because you don't know, are these cells that are progressing, are they sensitive to the old drug? How are they becoming resistant? And the thing is that you can develop resistance that develops in a heterogeneous fashion in different parts of the body. So you can have a cancer that's under completely excellent control in most of the body, but you have one spot that's growing. Now, you wouldn't want to get rid of something that's working for 98% of the body because one spot is growing. And so in that setting, we'll often do something like stereotactic radiation or some sort of ablative procedure to deal with that spot. And we now have drugs that target the resistance. Osimertinib is a prime example. We had many patients who for years were on erlotinib, gefitinib, afatinib, and this was from work by Dr. Sequist, which found that up to 49% of patients developed this T790 mutation. And because of work that Dr. Sequist and her colleagues did, we were able to see this and develop a drug to target it. And so that's how we were able to get osimertinib, is by understanding this mechanism of resistance. But take another look at this pie chart here. What you'll see, and this is to erlotinib and gefitinib, not osimertinib. You see that while T790 occurs in 49%, there's other stuff that can happen, right? So small cell transformation happens up to 14% of the time. We would not want to treat a small cell lung cancer the same way we treat a T790 mutant lung cancer, because our treatments won't work there. Similarly, MET amplification is a totally different mechanism of resistance. And understanding that mechanism of resistance is absolutely critical to understanding how we should treat it in the next line. And this becomes really, really complicated because every person is an individual. And when we talk about treating every type of cancer, it becomes very complicated for a doctor who treats every type of cancer to be aware of all of this complexity, whereas I have the privilege of just focusing on this. So I can say, okay, I can really focus on how am I going to manage my patients with EGFR mutant lung cancer that develop MET amplification, and really sit and think about that, because it's going to happen in my clinic because I see enough lung cancer. But it gets really, really complicated in the community. How can we get that tissue? And we're going to talk here about the liquid biopsy, Karen. So doing these repeated assessments are really critical, doing these biopsies, but nobody likes having biopsies. And so doing liquid biopsies are this novel approach. And so this is what a liquid biopsy is. This is from an editorial that we wrote. So you have blood circulating in the blood, you have cell-free DNA, and that DNA can arise from multiple sources. It can arise from clonal mutations in the tumor. That's really what we're looking for, but it could also arise from other sources. So for instance, in pregnant women, you can identify DNA from the fetus in the woman's blood. And so if you find a Y chromosome there, that's how you know you're having a boy. And you can also identify DNA from clonal expansion of white blood cells. So it gets to be quite complicated, but tests like Guardant and Foundation Act are ways to evaluate this cell-free DNA so we can sometimes avoid doing a repeat tissue biopsy. But I should mention that the sensitivity of these assays is not perfect. If I have a patient and they have a negative liquid biopsy, let's say I'm looking for T790 and I do a liquid biopsy and it doesn't show it, I don't stop there because the sensitivity of liquid biopsy is only about 70%. And it makes a big difference to that person. So what I will generally do is I will start with a liquid biopsy at the time of resistance to a tyrosine kinase inhibitor. And if I don't find a meaningful target, I will do a tissue biopsy, but you have to biopsy something that's growing. If you biopsy something that's not growing, you're not going to learn anything about what's causing the growth. I think one of the critical things to remember as patients is groups like EGFR resistors are really amazing. And I tell all of my patients about them. I think it's fantastic because the truth is you have a cancer that, or your loved ones have a cancer that is rare in in your local community perhaps, but 15 to 30% of all lung cancer is a lot of people. So you are not alone. There are lots of people who can help you on this journey, and I'm honored to help work with you guys. So I want to touch on some recent data on resistant. What are the typical resistant mutations and what drugs are available for them? Iris, you have asked a fantastic question, and it directly links into what I'm about to say. So I'm just going to go with the slides if that's okay. Because it literally is exactly what we're about to talk about. So this is the FLORA study. This is the reason that I tend to use osimertinib before as first line in EGFR mutant lung cancer. This is a progression-free survival curve which showed that osimertinib, indicated here in yellow, was superior to standard of care in terms of progression-free survival, and also the toxicity of osimertinib was better, the side effect profile. This is a forest plot from FLORA, and what I want to call your attention to, I know this is very confusing, but each of these rows represents a group of people. And then each of these little dots with the lines on either side of them represents the odds that it is better. And any little line dot thing that's on this side of the curve means that osimertinib was better, and anything on this side means that gefitinib and erlotinib was better for that group. So what you can see quite clearly is that for every group that they evaluated, osimertinib was better than the standard of care. And this is the overall survival data, which is not yet statistically significant, but sure looks like osimertinib will end up being better. So, Iris, here we are getting to your question. So we know that the mechanism of resistance to first-generation TKIs is T790. We are really just in the infancy of understanding mechanisms of resistance to osimertinib. MET amplification does seem to be a key mechanism. C797S may be a mechanism, as is small cell transformation. But the really critical question, which Iris, you touch on, is, well, what are we going to do about it? And Laura, you are hitting up the next topic we're talking about. This is great. I'm getting transitions from all of you guys. So MET is enormously complicated. So MET amplification, we say, well, okay, you have MET amplification. How are you going to target it? We have MET inhibitors. So it turns out that even defining what MET amplification is complicated. So I spoke about NGS before. It can also be identified on FISH. You can also do MET based on immunohistochemistry. You can also do MET based on a blood test. And no one really knows at this point which of those is the clinical biomarker of response to treatment. But we did see in the Totten study, which was presented at AACR this year by Dr. Sequist, that when she combined osimertinib with savolitinib, I know they name these drugs horribly. The goal of being an oncologist is to be able to say impossible words very quickly. So they combined osimertinib and savolitinib for patients after just a first-generation tyrosine kinase inhibitor. This is, you see the waterfall plot. It's very nice, but this is not as impressive to me because if you think about it, they were giving osimertinib in patients who had failed TKI, so we knew osimertinib works in that setting. But if you take a look here, these pluses indicate patients who were MET positive. And you also notice that some people were responding who weren't even MET positive. After osimertinib, though, you can see that there is a clear benefit to giving this drug. Response rate about 25%, but there were more people who did have an improvement in their disease burden, and it does seem like there's a lot of pluses here, indicating that MET amplification is happening. They looked for MET amplification here using FISH, but they showed that this combination was effective. I will say that the combination was pretty toxic, but it does seem to have some efficacy. Here's the toxicity. You can see that diarrhea occurred in 30% of patients, but grade greater than 3, nausea, fatigue, vomiting, there is pretty significant toxicity. Grade 3, so we grade toxicities in a clinical trial. Grade 0 means there's no toxicity. Grade 5 means that someone dies as a result of the toxicity. Grade 3 means that it's a serious toxicity. So these are, there's a good amount of toxicity seen here. One of the drugs that was presented at ASCO, which I had the honor of participating in, I was the senior author on this manuscript, was J&J 372. This is a bispecific antibody where one targets EGFR and the other side targets MET. This is the waterfall plot, which was seen after osimertinib, showing that 28% of patients had a partial response, and a good number of patients had responses, had clinical benefit. We also saw benefit regardless of the mechanism of resistance. This curve is, I didn't make this curve, unfortunately, but you can see that there's responses in C797S. MET amplification is this circle or it's the square, which is indicated here, but you can see that patients had responses regardless of their mechanism of resistance. Also, J&J 372 seems to have efficacy for patients with EGFR exon 20 insertion, which is historically resistant to other tyrosine kinase inhibitors. So that was really exciting. And the drug was pretty well tolerated in my experience. The big thing about this drug is it can cause an infusion reaction. Oh, Ivy just lost sound. Did anyone else lose sound? I still have sound. Oh, good. I'm glad you still have sound, Lacey. Well, I just finished, so that was my last slide. Oh, I'm right on time. Look at that. Fantastic. All right, so Ivy made a very good point, which is that I should not end this stream and start a new stream because then we'll lose people and it'll get very confusing for everyone. So what I will do now is I will just say thank you, and really thank you all so much for logging on and spending time with me tonight. I'm happy to answer any questions that you guys may still have, or if I missed any. Oh, lots of people can hear. Oh, good. I'm glad you can still hear. All good. Still have sounds. I have sounds. Oh, here we go. Oh, no. Someone says no sound. Try to close it and reopen it. That seems to work. All right, I'm going to answer this question. What is the average time before someone on Tagrisso becomes resistant? By the way, just so you're all clear, when I say the word osimertinib and Tagrisso, those are the same thing. as a researcher, I am trained never to use the brand name because it indicates favoritism or whatever. So I'll keep saying osimertinib if that's okay. The average time before someone on osimertinib becomes resistant really depends upon what their prior treatment is. So if somebody has osimertinib in the first line, they tend to, on average, have a response that lasts about 18 months to 2 years. In the second line, they tend to have a response that lasts around 9 to 12 months. There is a huge range on that, though. I have patients who have responses that can last years longer than that, and unfortunately, I have patients who develop resistance much sooner than that. See if I have other questions here. Okay, working now. Tara, I think the slides were sent by Ivy on the to the EGFR Resistors website onto the Facebook group. You can download them. Crystal, I see your question. I am not going to, it's not an odd question. Even before I read it, I know it's not odd. Here we go. Not smart. Okay, Crystal, I see your question. So I'm not sure that the blastomycosis is going to be relevant in this setting. So the NGS testing, what they do is something called, usually they do what's called macro dissection, where the pathologist will look at the slide, separate out the tumor, and identify and really draw the DNA out from that tumor. And so as a result, most of the DNA that's derived from the test is from the tumor. Now, the one exception is that sometimes you can have DNA from blood cells that are in the tumor, and that can look like clonal expansion. That's something called CHIP. But if you found EGFR and TP53 on your husband's mutation profile, my suspicion is that both of them are in the non-small cell lung cancer cells, because that's a very common mutation profile. As I mentioned before, TP53 is the most commonly mutated gene in human cancer. I hope that answers your question, Crystal. Karen, thanks so much. I'm excited to be participating in the J&J trial. When, if at all, do we give pembrolizumab or Keytruda? Lauren, this is a great question. The answer is very late in the treatment, if at all. And the reason I say that is that when we give patients who have EGFR mutant disease immunotherapy, what happens is two bad things. The first bad thing is that it tends not to work. The response rate in patients who received immunotherapy of EGFR mutant disease is very close to zero. In the trials that compared pembrolizumab, nivolumab, and atezolizumab, 3 of the FDA-approved PD or PD-L1 inhibitors for lung cancer, that was compared to docetaxel in the second-line management of lung cancer. There was a meta-analysis that looked at patients who had EGFR mutant disease or EGFR wild-type disease, and what they found in that study was that when you look at the EGFR mutant patients, the docetaxel was better than the immunotherapy. And that's really, beating docetaxel is a very low bar. So I would not use it in that setting. But in addition to the fact that it is not effective, it also tends to be quite toxic. Specifically, if a patient has immunotherapy in their body and then receives an EGFR inhibitor, there is a very high rate of inflammation in the lungs, so-called pneumonitis, which can be even fatal. So I'm very, very hesitant to use the drugs at any time in any time relation to each other. The only drug combination that has been shown to have possibly some efficacy is the combination of carboplatin, paclitaxel, bevacizumab, and atezolizumab, which is a quadruplet regimen, which they did look at as a subgroup that there might be some benefit in EGFR mutant disease. I'm not enormously convinced, but that is the regimen with the most data. It should be mentioned that in the specific FDA approval for that regimen, it says this is not to be used for patients with EGFR mutation or ALK translocation, but in the European approval, it says specifically that we can consider it in this group because they did evaluate that in the trial. Lisa, nice to see you on here, not only on Twitter. So this will be available, I believe, on the EGFR Resistors site. For the C797S trial, you talked about, can it cross the blood-brain barrier, Iris? So the specific drug that I spoke about, the JNJ372, is a monoclonal antibody, a large molecule, and it cannot cross the blood-brain barrier as a result. That's a major limitation of it as an agent. And so there are some drugs that are in development for targeting C797S, but one of the most interesting aspects is that if someone has only been on osimertinib and they don't have T790, then if I had a patient who's on osimertinib, they develop C797S and do not have T790, I would actually give that patient either erlotinib, gefitinib, or afatinib, because there are some preclinical data indicating that the older drugs actually work on C797S. But again, those also don't cross the blood-brain barrier very well. Osimertinib without T790, yes. So we use, Jeannie, we use osimertinib in the first line now for many patients with EGFR mutant disease. And because osimertinib inhibits T790, those patients will likely never develop osimertinib, never develop a T790 mutation. Sorry. So Tara, your question, upon progression on osimertinib, what kind of biopsy do you recommend? I usually do a liquid biopsy and then do a tissue biopsy of something that's growing. Oh, Ivy already answered the question. Joni, you answered the other question. What do we do when brain mets are present? We can do whole brain radiation therapy. So the management of brain metastases in patients with EGFR mutant disease, it's complicated. With osimertinib, we tend to have very good CNS penetration. But still, patients can develop brain metastases. I like to avoid whole brain radiation whenever possible and use stereotactic radiosurgery, something like CyberKnife or Gamma Knife, but sometimes that's just not possible because of the amount of tumor seen or where the tumor is. And I have close conversation with my radiation oncology colleagues. Hi, Kimberly. Good luck with the Tagrisso. Oh, I see. Crystal, you said that your husband only had liquid biopsy. I still think that it's all from the tumor. Basha, your question, what happens if it is TP53 and RB1 along with EGFR? So that mutational profile is very common, but one of the things we worry about when someone has that mutation profile is that at the time of progression, they may be at a higher risk for the development of small cell transformation. So I would want to make sure to do a tissue biopsy on a patient like that at time of progression. Father's suffering. I'm sorry to hear about your father, Melissa. You'd have to talk to your doctor specifically about the side effects. Generally, fatigue can happen with osimertinib. I don't tend to see shortness of breath or cough very frequently with the drug, but I'm sorry to hear your father's suffering. Lacey, I see your question. So one of the big things about BRAF, which needs to be noted, is that really the only type of BRAF mutation that's clinically relevant is a BRAF V600E mutation. If a person does not have a BRAF V600E mutation, I tend to ignore it. How useful is bevacizumab in treating EGFR mutant patients, Marilyn? It's a fantastic question. I could spend an hour just talking about that. It's very controversial, is the short answer. No one knows. Eric, does diet and exercise help prolong the effectiveness of osimertinib? We have no idea. No one has any idea the answer to that question. I think it's an important question that needs to be answered. But what I tend to say is that for my patients, exercise is always a good idea. Just a minute. Ivy, I think, let me see. Ivy thinks I didn't answer one of the questions before. Osimertinib without T790. Can someone get it if they're T790 after progression? Oh, so can someone, so if you're on, Jeannie, Ivy's referencing, she thinks that I misanswered your question. I apologize. So if somebody is on erlotinib gefitinib, they develop progression without T790, and that T790 negativity was confirmed on a tissue biopsy, and then you start them on chemo, for instance, it is very unlikely that that person will develop a T790 mutation because you're not selecting it for it using evolutionary pressure of a pill. So it's very unlikely, but you can always check with another biopsy. Let's go back to where we were. With EGFR, does immunotherapy not work on all PD-L1, even with higher levels? Lisa, it's a great question. I tend to completely ignore PD-L1 staining for patients with a targetable alteration because I don't think it means anything. I think I'm a 15. Iris, your question about using brigatinib for C797S, I think we are just learning about brigatinib's role in EGFR. I think we need to have more data, though there is a case report I know out there of the use of brigatinib in that setting. I personally have not done that. I would tend to prefer erlotinib gefitinib, though the advantage of brigatinib, it could be argued here, is that it has CNS penetration. It can cross the blood-brain barrier. Yeah, this is a very hard disease. It's a really, really hard disease to answer these questions. Garden was done upon diagnosis. Should RNA still be done? Tara, your question is a great one. If the garden was done upon diagnosis and it showed an EGFR mutation, then I don't think you need anything at time of diagnosis in order to start a pill. First line. Okay, Ivy's sending me a question. First line or second? Hold on, I think I missed a question. Amy, did I miss your question? Ivy, I don't see this question that you're referencing here. I'll answer these questions while I'm waiting, though. Which companies do NGS? Lots of them. Caris, Foundation Medicine, MSK Impact, and many of your local academic sites will have their own institutional panels. CBD oil and THC. Yes, lots of questions about that. No one really knows, is the truth. For many herbal supplements or things like that, and CBD oil would be included in there, they can be sold with very little oversight in terms of what you're actually getting. So that's what makes me a little bit nervous. Excuse me. My general rule in terms of THC is that if I have a patient who has lung cancer, I don't want them smoking. So if they are obtaining marijuana legally and want to eat it, I'm generally okay with it, though admittedly we have very little data on safety. For CBD oil, most people are not smoking that. They're generally taking it in the form of capsules or the actual oil itself or cooking with it. I don't know what people are actually getting in that setting because it's less controlled than a medical marijuana dispensary. And so I worry that my patients are just buying expensive vegetable oil, but I don't actually know. We don't know what's going on. Follow-up. So Tara, follow-up to Garden being done at diagnosis. Should RNA be done at progression then? I would consider a DNA and an RNA-based assay at the time of progression for any patient who's progressing on an EGFR tyrosine kinase inhibitor. Kimberly, your question, what's the median time for osimertinib to work? It tends to work very rapidly, usually within days to weeks. Tina, can we take cod liver oil to remove dead cells of cancer? I'm not aware of any data supporting that. I'm also not aware of any major risks there. Is Foundation 1 an NGS? Yes, it is an NGS. You're very welcome, Kimberly. What are your thoughts on the Signatera test for ctDNA demomer long before a CT scan? I don't know anything about a Signatera test. I don't use that test. Peter, it's negative for T790 by tissue biopsy after a lot and I went on chemo after 20 months that progressed. It's retested. Yeah, Peter, what you're saying is what I was trying to reference before is that each tissue biopsy, you're putting one little needle in there. It might not have been on the cell that was growing and it might be negative for T790. So I really do check repeatedly. Oh, that's very kind, Amy. So I think I got everyone's questions. Oh, no, I didn't. Oh, that was just a thank you. Oh, you're very welcome. I think I got everyone's questions. I think I'm just going to check in with Ivy to make sure that she thinks I did too. Oh, new comment. Oh, great. Well, thank you all so much for having me. It's a real honor to be able to speak with you guys. And thank you so much for all the wonderful work that you guys do as a group. It's really great. Oh, I got another question. Would I recommend taking supplements with Tagrisso? I wouldn't. I generally would not. And the reason for that is simply that I don't know what's in them and I'm worried that it could interact with them. Radon is definitely a known cause of lung cancer, Kimberly. We're getting more questions. I'll answer them. Specific. You know, if you've been on the osimertinib for a bit and you haven't had shortness of breath or a cough or worsening inflammation in the lungs, that would be good. That's fine. I wouldn't go looking for a problem, but I get worried about it. And in fact, I sometimes don't give my patients with EGFR mutation durvalumab, but that's a practice difference. Some people do, some people do not, and it's a controversial topic. All right, thank you so much. I'm going to sign off now, so you guys can all get some rest or whatever. And I think I am. Oh, thank you all so much for having me. Have a great night.